Ladies and gentlemen, welcome to today's Supportive Care Coalition webinar. Today's presentation is titled Responding to Opportunities for Collaboration During COVID-19, presented by Dr. Mimi Pattison and Dr. Bethany Kapp. Before we get started, I'd like to mention that today's session is being recorded and you are currently in a listen-only mode. You will be receiving an email tomorrow with access to the recording to listen to on demand. We will be having a question and answer session at the end of the presentation, and you may type in your questions to our speaker at any time using the questions panel on the right side of the screen. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you, Brianne, and welcome everyone to today's Supportive Care Coalition webinar. For those of you learning about the Supportive Care Coalition for the first time, we are a partnership of Catholic Health Ministries from across the U.S. dedicated to advancing excellence in palliative care through ongoing advocacy efforts at the local and national levels, through interprofessional education, resources in healthcare ethics, and the integration of spirituality in palliative care practice. Coalition members have complimentary access to these monthly webinars, numerous resources on our website, and a community of like-minded learners from all disciplines represented in palliative care. As Brianne mentioned, today we are especially excited to welcome Dr. Mimi Pattison and Dr. Bethany Kapp. Dr. Pattison is the Regional Medical Director for CHI Franciscan Hospice and Palliative Care in Tacoma, Washington. She has been with CHI Franciscan Health for 30 years. She's board certified in internal medicine, nephrology, and hospice and palliative medicine. She has worked in hospice and palliative care for the past 20 years and has been the physician leader for program development at CHI Franciscan Health. Dr. Kapp completed medical school at Tulane University and subsequently completed her residency in emergency medicine at the University of Cincinnati. She practiced emergency medicine for 10 years before completing a fellowship in hospice and palliative medicine at the University of Texas at San Antonio. In 2016, she started the palliative medicine service at the Highline Medical Center. And so without any further delay, I will turn it over to you, Dr. Kapp and Dr. Pattison. Welcome and thank you for joining us today.
Good morning, everyone. Thank you so much for that welcome. Thank you so much for inviting us here today to share our experiences with you guys. Really grateful. And thank you too to the Supportive Care Coalition for hosting this opportunity for us to share our ideas. There's so much good work and so many innovative ideas happening out there right now. And so it's exciting to be able to get together and share with one another. I see that my computer is talking to me about my connection being slow due to the webcam. So I am going to...
You look fine. Keep going. Yeah, you look fine.
Okay.
The camera was doing okay.
And can I please advance the next slide?
There you go. Yeah.
Please excuse me having some technical difficulties with the slide advance. And could we go to the next slide? Thank you so much. And
There we
next.
Go. Great.
Perfect. So thank you again for having us here to speak with you today. Really grateful. And what we wanted to talk about today was a little bit about the collaborative relationships that we've developed within our local community in order to provide better care to our patients in the pandemic, really in order to provide best care to our patients and to serve the people that are the most vulnerable. The relationships that we've developed have been with the emergency department, with long-term care facilities, and with EMS. And so really quickly, I'd just like to go over our objectives for today. First, we want to discuss opportunities for collaboration with the ED to provide palliative care to critically ill individuals in a crisis. Next, we'd like to list 2 advantages of the healthcare system collaboration with community long-term care facilities in the setting of a pandemic. And finally, we'd like to discuss the opportunity for a collaborative relationship between EMS and hospice or palliative care to improve access in the home. Next slide, please. So before we get into that, I want to take a step back and just remember the context under which all of this started. We began working much more closely with our emergency department colleagues towards the end of March, which it's hard for me almost to remember now 8 months into this pandemic what things were like in February and March, but it was a markedly different landscape for us back then. In fact, it was the beginning of February before COVID was even named. So February 11th was when the World Health Organization gave this entity, this virus and the disease it causes, the name COVID-19. It was the end of February that the United States reported the first death from COVID-19, and that was reported just outside of Seattle, so really close to where the hospital is that I was working in. At the same time, our state governor announced a state of emergency due to COVID-19. Middle of March, 1 month after the World Health Organization proposed the name COVID-19, they declared COVID-19 a pandemic. As we moved on into the middle of March, it became clear that we were dealing with an outbreak locally at the Life Care Center of Kirkland, which I'm sure many of you heard about. Sadly, by the middle of March, more than half of the deaths that we had in King County were linked to that outbreak. Some of those individuals we even actually saw at my local hospital due to other hospitals in the area being overwhelmed. As March went on, our cases continued to go up, as did our deaths. There was a lot of unknown happening around this time at the end of March. We have many of the same unknowns now, although I think we have a little bit more information than perhaps what we started with. At the time that this started, we didn't know how contagious this was. We didn't really know what it was exactly that we were dealing with. At the time that this started, we had no idea how to treat it. PPE wasn't plentiful. Our staffing, I would say, was normal, although I'm not sure how it is in your hospital, but I think normal staffing may resemble understaffing in some situations. So really a culture of fear around the end of March when this was all started. Next slide, please. And so I work at a small community hospital just south of Seattle when all of this was ramping up here in Seattle at the end of March. And as I was mentioning, there's really kind of a culture of fear around this. People not knowing what's going to happen. We were under lockdown at the time. The lockdown had started, I think, a week or two prior. People are scared, not knowing if they are going to catch this or if they're going to take this home to their family. And that was the environment that we were working in when we received a phone call at the end of March from the emergency department. And it was a desperate call from a colleague of mine, a friend, a fellow emergency physician, just saying, please, can you help us here? And what was happening is we were having a small surge of critically ill individuals arriving to our emergency department. I say a small surge because we're a small hospital and so easily overwhelmed by numbers that might not overwhelm a larger center. But nevertheless, we were seeing a much greater amount of critically ill individuals coming in than we did before, many of them being put on ventilators. Now, one of the different things that was happening earlier in the pandemic was around ventilating patients, so placing patients on a breathing machine. Early in the pandemic, we were very concerned about what we call aerosolized particles. So this idea that the virus is in the air and can be transmitted that way. And so early on, we were very interested in trying to reduce the number of things that we did that would generate these kind of particles in the air, trying to reduce the danger to everyone there. And so, unfortunately, many of the supportive treatments that we use to support individuals that can't breathe, unfortunately, generate aerosolized particles. And so we were moving quickly to put people on ventilators early in the pandemic in situations where we might not normally have before. And so we were placing more people on ventilators than normal. And when they called us, they asked such an important question. Should we really be intubating all of these people? Is this really the best care? And the elephant in the room, are we going to run out of vents? Do we have enough? Do we even have enough beds? Can you please come help? So my partner and I went over to the ED amidst this to try to figure out what we could do to possibly help our colleagues in this situation, in this environment of fear, where we're already having thoughts of scarcity. And I will say this is one of the days that I was just amazingly grateful for my team. At the time, we were a team of 2. I work very closely with a palliative care nurse that I've had the privilege of working with over the past several years, who is not only just impressively skilled, but unbelievably compassionate. So I was very fortunate to have a partner throughout this process. So that day, when we arrived in the emergency department to help, we found frantic staff. We found a lack of staff. We found a lack of protective equipment and a lot of sick patients. The first patient that we attended to actually was an individual for whom we say CPR was in progress. By that I mean it was someone that was actually receiving chest compressions and someone that we were breathing for. So someone that died and we were attempting to bring them back to life. So unfortunately, despite the medical team's efforts, we were not able to bring that individual back to life. What we were able to do, though, was immediately contact the family and disclose that serious news in a gentle and compassionate way. We were able to provide immediate support and information to the grieving family in a situation where the individuals in the emergency department didn't have the time and may not have even had the skills to do that. So we were so grateful that we were available. The second person that we took care of that day was an elderly individual with severe lung disease that came in, as many people do with COVID, with difficulty breathing. And they were worried that they were going to have to put this person on a breathing machine. This is a particular concern for this individual because in the setting of such severe lung disease and older age and many other medical problems, the team was worried that if we started treatment with a ventilator, that perhaps this patient could spend the rest of their life on a ventilator. And worried, is this really what this individual would have wanted? So what we did in this situation was we were able to locate family and have a rapid goals of care discussion from the ED with family, where we were able to rapidly ascertain this individual's values and preferences, and then with the information we knew about their medical situation, make informed recommendations to this family about next steps. And in this situation, I'm just so grateful that we were there, because what we found out was that this person actually did not want any artificial measures taken to prolong their life. And this person had actually been on a breathing machine multiple times previously and did not want to be on a breathing machine again. In fact, what we found out was the reason this person came to the emergency department was not for medical treatment to live longer, but for treatment for the symptoms of their respiratory distress, so that they could have a peaceful, natural death. Unfortunately, this person did end up dying that day. The one thing that I do feel very grateful for is that they did get very good symptom management and were able to die peacefully and comfortably. It was at the same time that we weren't allowing visitors into the hospital. And so in this situation, we were able to assist the family virtually to be able to see their loved ones, which was very impactful for the family and for us. The other wonderful thing about this situation is that it freed up the emergency department personnel, staff, and resources to direct their efforts towards people that did want resuscitative efforts and to people that would benefit from those efforts, instead of directing them towards someone that didn't. We all, when we debriefed at the end of the day with the emergency department, and my nurse and I, we felt like we had made an impact, like we had provided good care. And then we went home. So we came in the next day and the same thing happened. We were continuing to have a surge. We were continuing to have critically ill patients arriving at the ED near simultaneously requiring intubation. And we got another call. Can you please come back and help? And so we did. And from those phone calls, we had the birth of our palliative medicine emergency department rapid response team. Next slide, please. It's so interesting because this is actually something that I would say, dreamed of doing. Since I practiced emergency medicine full time, my hope was really always to try to get palliative care as early as we possibly could. And what better place than as soon as people arrive in the hospital? So I was really just excited and overwhelmed with gratitude at the opportunity to be able to provide this care. And so when we responded to the emergency department, we helped to deliver serious needs. We helped to identify goals of care, values, and preferences. But the other thing that we did was to help manage expectations. And by that, I mean expectations of staff, expectations of patients, and expectations of families. And so we spent a lot of time talking with folks about, here is your diagnosis. Here is what's happening in your body. Here's what we expect might happen in the next 24 hours, or what might happen over the next few weeks. In really managing expectations and providing information about what's coming next, and then using the information that we gleaned about their values and preferences to make recommendations as the days went on, as we continued our relationship with people throughout the hospitalization. And so we were able to start that relationship on day one, set up expectations, provide information, and continue that through the hospitalization. And even in some cases, we were able to celebrate with them when they left the hospital, which is just pretty amazing. I would say maybe, I don't know, 4 or 5 days into this, we kept getting calls to come back to the ED, and I ended up speaking with the ED leadership and the hospital leadership, and actually we put out a recommendation to the emergency department providers from the hospital to actually consider consulting palliative medicine anytime during the time that the palliative medicine team is available, which unfortunately is just Monday through Friday during business hours, but to consult us anytime we had someone coming in that was receiving CPR or that was critically ill, or potentially requiring life support. And so during that period of surge for about 2 weeks, that's what we did. We made the emergency department patients our priority and responded as best as we could emergently in real time to meet the needs of the patients. Next slide, please. And anecdotally, from talking with staff and from talking with the patients that we talked about, I think that we were able to make a significant impact, one person at a time, in decreasing moral distress from the staff, in making sure that we're providing goal concordant care. What I mean by that is we're providing the care for you that you want. We were able to get in quickly to provide aggressive and skillful symptom management to people that need it. And we were able to help the hospital to better direct resources to people that would benefit from those resources and people that needed and wanted those resources. Other benefits that we would see from this align with benefits that you see cited in the literature about early palliative care consultations, such as decreasing length of stay and decreasing utilization of the ICU. Also, I wanted to mention, as we were having these conversations and responding in the ED, we leaned heavily on 2 different communication tools to guide us through this. One of which was actually developed by largely by Dr. Oreghi and Dr. Pattison in our own palliative medicine and spiritual care department. I was so grateful for that communication guide. And the other one that we used frequently was Vital Talks COVID-19 communication guide. If you haven't had an opportunity to take a look at those communication guides yet, I would certainly recommend doing that. And so grateful to the folks that put those together for us. In summary, I feel like the rapid response PalMed EM team was something that was really beneficial, not just to patients, but also to staff. I feel like it really helped us provide good goal concordant care. And as I envision the future, I wonder if this is something that we could do not just in a crisis, but that we could do more frequently on a more routine basis if we had the capacity to do so. And at this point, I would like to turn this over to my colleague, Dr. Mimi Pattison, to discuss some of the other collaborative relationships that we had an opportunity to develop during this pandemic.
So thank you, Bethany. It's just great to hear your story again and all the great work you did in collaborating with the emergency department at your hospital, and that you continue to do. So I want to switch gears a little bit here and talk about a couple of other opportunities that came to us during this COVID time. And the first opportunity is to develop a drop team and respond to community needs in long-term care. Well, I know you're all saying, what in the world is a drop team? And I must admit that was my first question also. And because I envisioned us kind of learning how to parachute in here and there and give equipment or whatever was needed. But anyway, the idea, I guess, originally was from the University of Washington when they reached out to the facility that had the initial cases. And there really was need for some outside support. And so ultimately, our CHI Franciscan system was asked to develop some drop teams and reach out to the facilities in our community. And we in hospice and palliative care were requested to reach out to, maybe 4 or 5 facilities for general support. This was not doing the work that we do best, but this was really more general support. And so we really kind of questioned what was that going to be like. Ultimately, we ended up supporting more than 13 facilities in our communities. And actually, a lot of those facilities, we had existing relationships because so many of our patients are in the facilities. So what we did was develop a multidisciplinary team consisting of a nurse practitioner, myself, an RN, and actually he was our education RN, and then a department assistant. And we created our own phone line, and we actually staffed that phone line 7 days a week initially during business hours. So our drop team, as I said, consisted of an ARNP, and she was redeployed from the outpatient setting where she was doing outpatient palliative consultation services. Our team got together and we figured out really what can we do, how can we reach out and help these facilities. And it was so important to determine what we could do and especially what we could not do. So we established an introductory phone call with them one by one and with their executive director and director of nursing. We actually got quite mixed reactions because they weren't sure what we were doing and if we were going to be coming in and telling them what to do. The reality is a lot of these facilities were dealing with corporate headquarters who were in a different part of the country and maybe really hadn't had the same or were not having the same experience that we were here in the Northwest. So they agreed to talk to us, and we told them sort of what we could do and that we would, be available to talk to them anytime. And ultimately, what we ended up doing was sharing resources. And those resources included maybe some testing supplies that they didn't have access to. A lot of what we did was really education around donning and doffing PPE, how to preserve PPE. A lot of the facilities did not know where to get the PPE, and we kept up on everything that was happening in our community. So we would know local resources, whereas previously they had just been dealing with their corporate headquarters. So a lot of it was education, and then we were sharing with other facilities what was happening and how to cohort patients and what to do. Issues came up around restricting visitors, and that was very difficult, and we helped them through that. The other thing that we did, and Dr. Kapp alluded to that a little bit, we created actually some scripting guidelines on how to have conversations throughout our system, both in the emergency room, at the bedside for our inpatient doctors, and we actually created a special scripted document for how to have conversations with chronic and seriously ill patients in a nursing home who are likely not going to benefit from being hospitalized for COVID. So that was a separate call to their medical staff for the scripting and support to how to have those conversations, because it was a different conversation. We all know typically when something happens in a nursing home, 911 is called and off they go to the hospital, and now they were having very different conversations. So we also couldn't help but putting on our hospice and palliative care hat and talked about symptom management. And so this was something relatively new to them. And there had been some national guidelines actually published by CAPC we modified those a little bit and shared that resource with them. And then we're also available to help them with symptom management if they called us. So as I said, we trained in testing. We actually went out to many facilities and actually showed them how to test so that then they could be able to test their staff and patients. But I think, one of the most important aspects of this whole drop team was really the emotional support that we gave to them, because they could call us and just ask any questions they wanted, whether they needed equipment or needed somebody to talk to or how to talk through a really difficult conversation. So what were the outcomes of this intervention? Well, clearly we had stronger relationships in our community, and as I said, we had pre-existing relationships with these facilities because of all the patients that we cared for in them. And then, of course, with their visiting restrictions, and they didn't want to let hospice staff in. Hospice staff are considered essential, but they always kind of played the corporate card on us, and they said our corporation doesn't acknowledge that, so you can't come in. But we just had a different relationship at this time, and I think that actually helped us finally get into a number of facilities where visiting was so restricted, and also to help them to ease their visiting restrictions when someone in their facility was dying, and we were there to help them with that. We were able to refer them to certain resources, whether it was testing resources, but especially for PPE because it was in such limited supply initially. So what did that do to our consult service by pulling, a full-time provider away from that work in the community? Well, actually, it delayed some of the palliative care consults that we were able to do in the home. But in a way, that was actually balanced by some patients and families did not want another visit. And this was actually well before we had developed our virtual care, which I think most of you in the audience have heard about how systems have developed virtual care resources during COVID times. And I think it's going to be just a great outcome of all of this pandemic. So it really helped us identify the need to establish virtual care for our service line. And that's exactly what we did. And ultimately, our AR&P was, sent back to the outpatient service as we had fewer and fewer calls as things became more stable and established. So really, lots of great outcomes from that intervention in reaching out to communities. And initially, it wasn't to do the work that we do well, but it was to just teach some basics in infection management, and the emotional support, I think, was probably the biggest thing. So now I want to talk about our collaboration with Tacoma Fire and their emergency medical services. So this starts with a story, and it's a great story, and I'm just so proud to share it today. But the story begins with a 911 call to the home of a 48-year-old male who was in acute respiratory distress. And of course, this call came in at midnight, as you can imagine. And this gentleman was chronically ill. He actually had been on hospice previously, but had improved and was ultimately discharged. He had 24-hour caregivers in the home. He was being really well cared for. And I don't know the story of how he ultimately ended up being exposed and was tested for COVID and was found to be COVID positive. They were worried about how he was going to do with a COVID infection and actually called the hospice back that had cared for him previously. They came out, and without any, experience in dealing with COVID, he looked fine. He was having no symptoms at the time, so they did not admit him. And interestingly enough, just a few hours later, he developed severe respiratory distress, and 911 was called. And this was a great learning experience for everyone involved, because we really, in the beginning, did not appreciate how quickly these chronically ill patients can change. In a matter of minutes to hours, can become critically ill with severe respiratory distress. So 911 was called and they responded. There was a pulse form in the home that designated no CPR and do not transport. Well, when they show up to somebody in respiratory distress, obviously that's one of the first things they do besides, give them oxygen and is get ready to transport them. But this person's brother was called, who was the POA, and he just absolutely refused to have his brother transported. He had promised him that he would never, ever have to go to the hospital again. Apparently had some traumatic experiences. So here we are at the beginning of a pandemic. A chronically ill person in the middle of the night is in acute respiratory distress, and really there are no medications in the home, nothing to do. The paramedics on the call had some IV fentanyl, and I think they gave him a dose or two of that. That wears off very quickly and was obviously not going to help him. And it was clear that the care needed to be given in the home. So as the story goes on, the medical director for Tacoma Fire was called and actually went out to the home. And again, the middle of the night. He did not know just exactly what to do, so he got on the phone and actually called our triage number. He had a little trouble finding the right number, and anyway, finally got to the triage nurse. And for those of you who don't know, our triage line is a one phone number call where there's an experienced RN on the other end who can give you guidance and help during an acute situation. So he said to her, how would you guys manage this patient if you were in the home and you were needing to manage this respiratory distress? So he was instructed about our comfort kit, the medications that are in it, and how we would really dose these medications for this particular individual. Well, that was fine. Now he had the knowledge on what to do, but of course he had no medications. So this medical director actually wrote out the prescriptions, found the closest pharmacy, 24-hour pharmacy that had the medications, went to get them, and brought them back to the home. He then administered the first dose of the medications and gave guidance to the caregivers on how to administer the medications until hospice could get out the next morning. I think this was just such an amazing display of respect and of compassion and of honoring the pulse forms, which always doesn't happen when some things change very quickly. So I'm just so proud of him and proud of the work he did and the fact that he reached out to us to collaborate with and about how this person's symptoms were managed. Well, the story goes on, and the outcomes from this situation were that this patient that had developed a respiratory crisis very quickly had his symptom managed, and what he wanted and what had been promised to him was respected. Lessons learned: respiratory symptoms can develop extremely rapidly in chronically ill patients who are now COVID infected. We established a new relationship with EMS. Previously, our relationship had really been informational. They would maybe call us when they were called to the home of one of our patients. We would exchange some information or whatever, but it was strictly informational. It was collaboration in some sense, but this was a whole different level of collaboration. What we were most excited about is that we received an invitation to come out to their training center and to give a presentation about hospice and palliative care to their staff. So Diane and I were actually the very first visitors out to the EMS training center in Tacoma as we moved into phase 2 of recovery. We could have a total of 10 people in the room. So we went out there one afternoon and probably spent a good couple hours talking to their medical director and staff about hospice and palliative care. And I guess I wasn't really shocked about what we learned. But they told us that they had been told that if they ever transported somebody on hospice, that they would automatically be discharged from hospice, or that never under any circumstances can a hospice patient go into the hospital or to the emergency department. They just did not understand the difference between palliative care and hospice. So we were able to actually dispel many, many myths. And then we also talked about COVID symptom management during an acute infection. We then were actually invited to present to the paramedic training that is coming up this January. So we're on their calendar, and we're going to make sure that we get out there again. After that first episode, we actually were just getting ready to transition into a new medical record. So things were a little bit unstable for us, but we did share some cell phone numbers and try to figure out how they could do a direct referral process and emergency admission, and get the patients cared for that they were called, or that 911 was called to evaluate. And we are now getting stabilized on our new medical record, and we are planning on establishing a direct referral process so they can call us directly, get the order for admission from their medical director, and that our nurse would go out and do an emergency admission really anytime, day or night. So I think that's probably the greatest outcome of all of this, is establishing this resource for them and for patients in our community, because we all know about how many calls these folks attend. And if they could begin to do more education to the patients and families, either about palliative care or hospice, I think it would be great. So what are the takeaways that we've learned from all of these opportunities that came our way during COVID times? Well, clearly, as Dr. Kapp said, the earlier the better for palliative consultations. We know that on a good day, and especially in COVID times. And managing expectations. Managing expectations is so important. And I'm thinking that expectations are probably very different now than they were way back in March, when nobody really knew what to expect. And but managing expectations is a huge part of intervening during this time and giving serious news and making a plan for ongoing care. We clearly found out we all have the ability to shift gears and do other work, and we did that, I think, and we did that well. But of course, we always find time to do a little hospice and palliative care work on the side also. And I think most importantly, we all know that the EMS personnel are an untapped resource for our community to be able to provide and encourage patients and families to seek resources of palliative care and hospice. And I'm hoping that in the next couple of months that we have really a very solid referral process whereby EMS can call us anytime, day or night. We can respond and get a nurse out there in a very short period of time to get a patient that doesn't want to be transported, to get them admitted to hospice in their home and honor their wishes. So with that, I would like to invite Dr. Kapp back and Denise, and I am having trouble advancing this slide. I'm going to click it again.
Well, while you do that, I will thank you both for sharing great examples, as you said, Dr. Patterson, of this agility or shifting gears, responding to the needs of the moment. And so thank you so much for letting us in behind the curtain, if you will. And I will invite those of you who are listening in to navigate over to the question and answer panel and begin, as many of you have already, typing in your questions for our presenters. To kick that off, I am curious if either of you have questions for each other.
I'd be happy to start. And, I talked a little bit about managing expectations and how my sense is, and I am not at the bedside like Dr. Kapp is. And are those expectations different these days now that we're seeing a new surge in our community than they were initially? Dr. Kapp, I'd like to hear you respond to that.
Oh, Dr. Kapp, I think you're on mute.
Thank you so much. And thank you so much, Dr. Pattison, for asking that question. Things have changed. They are different. It's interesting with all of the information that we have access to at our fingertips these days. Some of the more common questions now are that I've heard is, why aren't we treating with hydroxychloroquine? Why has my loved one not received this medicine or that medicine that may have been talked about on the news? Or even having people, I want the same treatment that our president received. Why is that not being made available to me? So yeah, it's just been interesting, so interesting in this time of social media and of information sharing. The questions that that people come up with. I even had someone ask me about bleach once.
Oh no.
Wow. Well, an opportunity, as you both highlighted, a big opportunity in somebody asking for bleach to manage expectations, as you both mentioned, very important part of this skill set that palliative hospice folks bring. How about you, Dr. Kapp? Do you have any questions for Dr. Pattison?
I do. I was curious actually about what some of the other myths were that you heard from EMS.
Most of them were around how they can potentially intervene, like the idea that if they transported somebody, they would be, kicked off hospice and couldn't get back on. And they really didn't have a good sense of how you refer somebody and when are they hospice appropriate. Some of them really had no idea, and certainly no idea about access to palliative care for chronically ill, which they get called a lot of times for people with, symptoms or just who are declining, who may be not appropriate for hospice, but would be very, very appropriate for palliative care intervention. So for them to really be able to start that conversation in the home, I just think would be great for patients and families and really open up some access to that important care.
Mm-hmm. That's what's so exciting about the invitation to go and participate in their education event in January. We'll have to have you back and hear about what you presented and the response. And I just see a lot of potential there to really impact folks like the gentleman you described in your case, where he didn't have too many options at that point other than to call 911. So with greater education and understanding on the part of the EMS folks, maybe the chief medical director of the fire department wouldn't have to go out in the middle of the night, at least not every time, we hope. Yeah.
Right. And, I don't know why that can't happen in any community. Reaching out and collaborating with them in a different way than we ever have, particularly in COVID times when people don't want to go to the hospital and symptoms change so quickly and dramatically.
Yes, agreed. One of our audience members has asked about the challenge and any tips both of you have about having these very important, often sensitive, emotional discussions and interactions over the phone and or telehealth platforms. Any tips for us?
I'd be happy to start that, and Bethany, you can add to it. We are actually doing some targeted education for our clinicians about communication in telehealth. And it is so important because everybody is really initially was very much afraid of it. And so we are targeting the clinicians that are doing virtual visits on communication techniques. And just to share today, one of the most important techniques is to convey empathy and to take that time to use silence and to acknowledge the emotion and saying, you know, I this is hard for you. I can tell by your voice. Or if they do have some kind of video, that is obviously even a little bit easier. But that we call it telepresence, and just and that has to do with empathy and responding to the emotion. You could text them the information you want to give them, but communication is all about, you know, the meaning and responding to the emotion and an exchange of meaning rather than just information.
Gosh, I agree with everything Dr. Pattison said wholeheartedly. The one thing that I would add to that would be that even on telehealth, I think we still have the opportunity for authentic presence in the same way that we do when we are present at the bedside. And I would just encourage all of us to take that moment before our interaction with someone, to take the pause or the breath and bring ourselves back to the present and to this moment of being with that individual, even though it's on the phone, rather than perhaps multitasking as we can do now that we're on our computers.
Yeah, well said. Well said. You're right. There is that temptation, especially if we're not on a video platform, right, to do other things while we're on the phone. Excellent. Thank you both for that. Our other question from our participants is asking about this idea, I guess, that they're considering in their area about a county-wide repository for advanced care planning documents. They didn't specify, but I would invite you to also comment whether it's advanced directives and or POLST documents. What's been your experience with those specifically during the pandemic?
You know, I'll respond to that initially. We, over the decades that I've been doing this work, have tried to have some kind of a central repository for those documents, and it just has not worked well. And for, you know, now we have the POLST form that the patient keeps in the home, and sometimes those are even a surprise to the family. So, you know, the most important part about all those directives is the conversations that go on. And I think that we need to put as much effort into encouraging those conversations as we do to creating a paper document and figuring out where to find it. And, you know, a lot of systems in our electronic medical record, we are activating a special section where those advanced directives can be seen. But I have been disappointed, and we just haven't been successful in doing kind of a central repository.
Good to know.
In thinking about that question, I echo what Dr. Pattison says about the conversation being the most important part of that process. I say that just based on my own anecdotal experience at the bedside and in the emergency department. Even when we are able to locate an advanced directive, it's been my experience that they are not always honored, or not always honored until we have reached someone that is able to confirm that advanced directive, which is a separate conversation, but yet just reinforces how important it is to have that conversation. So when your family members get the call, they know what the preferences are and can honor.
Mm-hmm. Mm-hmm. Excellent point. Yeah, I recently on the National Academy of Science, Engineering, and Medicine workshop on advanced care planning, one of the presenters was talking about meeting folks coming into the emergency room with Pulse on file in their EMR that they didn't even necessarily know about and or know the content of. So it, like Mimi said, it goes back to the conversation, and those conversations don't usually just happen once. Things evolve, things change.
Right, exactly.
Mm-hmm. Mm-hmm. Well, we are about at time. I didn't know if there was any additional words of wisdom, of hope, encouragement for us all, for teams out there that either of you might want to share. It seems like you are bearing up. Your resilience is showing, shall we say? Anything you'd like to say to our teams out there?
I would just like to say, and I love that you ask about teams, because it is so important to be part of a team during this time and to support each other and to know that you don't have to feel like you have to do it all. And we all do what we do best, but there's always a part of us that can check and adjust, if you will, and do something different. And we may be called upon to do that. And you can do that. When we were first called about these drop teams, I thought, I can't do one more thing today. That just is not possible. But it is. We take a deep breath and say, what's really important. And somebody's asking me to do this for a good reason. And, we did it. And a lot of positive outcomes. So be prepared for some good outcomes also, and take care of each other.
Thank you, Dr. Pattison, for your words of wisdom. I guess I would just like to offer gratitude to everyone out there, to all of the palliative care teams. We are doing good work. We are doing hard work, and you are out there taking care of my friends and family. So thank you.
Beautifully said, both of you. Thank you so much. Well, thank you again for joining us. As I mentioned, as we got together on the platform before this presentation, you two have the distinct honor, and this will be a reminder to our audience, of presenting the last webinar for the Supportive Care Coalition in this current formation. We will be on a short hiatus, and we will reappear as a part of the Catholic Health Association. And you can see our recent press release, hopefully many of you received yesterday, and a link to the palliative care page on the Catholic Health Association website, where you will eventually, give us a couple moments to transition, you will eventually be able to locate all of the supportive care resources, and old ones and new and more to come. So I thank you so much, both of you, for honoring us with your presence on this last one. And for all of you who are on the line, we would like you to stay on just a moment more as the webinar ends. There will be a brief survey that we'd like you to fill out and give us feedback, because we do use that feedback to plan future webinars. Today's webinar was recorded, and you will receive a link to the recording in about 24 hours or so via email. Thank you very much, all of you, for the good work you're doing. As Dr. Katz said, stay well and be safe. Take care.